Good evening, and welcome to AI in Medicine, a series of panel discussions exploring artificial intelligence presented by community television and the Santa Cruz County Libraries. Tonight, we'll focus on artificial intelligence in medicine. We'll hear from doctors who practice in hospitals and a cancer researcher. The American Medical Association recently released the results of a survey of their members regarding AI. They titled the press release Physicians Enthusiastic but Cautious About AI Care. It seems doctors are excited about the relief properly programmed AI assistants could provide with administrative activities that kind of cut into the time they'd rather spend with their patients. Their biggest concern was that AI tools might impact their relationship with patients and patient privacy. To help us understand the potential improvements and risks of AI in our healthcare, we've invited two physicians and a cancer researcher who will share their experience with AI in medicine. Each of the doctors will speak for a few minutes, and once they've all spoken, they'll address your questions. If you're watching on YouTube, type your questions into the chat. Now, without further ado, I'd like to introduce our first speaker, Josh Stewart, PhD. Dr. Stewart is a professor of biomolecular engineering at UCSC. He has experience in developing computational models and a background in machine learning. He was the co-leader of the Pan-Cancer Working Groups for Cancer Genome Atlas Project and the International Cancer Genomics Consortium. Welcome, Dr. Stewart.
Thanks for having me. This is a really timely panel, and I appreciate the opportunity to share thoughts with these other experts. I think we're at a very critical point in time to think about this and talk about it as a society. So I don't think anybody has the right answer yet, and I think it's really important to have open communication. It's an exciting time. I think it's full of promise and hope from a research perspective, but I think it's also shadowed by a lot of uncertainty about how we can use these new models. So there's anxiety with the excitement, which is interesting. And we should all, take a step back and really think carefully. I can speak from my perspective in cancer research. We've seen amazing milestone kinds of breakthroughs in the last couple years. The technology I think we've all heard of or maybe are aware of, like from the large language model community, ChatGPT, OpenAI, right? All the talk and buzz. These things have already permeated my field. There are, not to get too technical, but these transformers, the attention models, if you hear about that, are able to find out what in the input they're given is helpful for the prediction task. And that concept generalizes into using large-scale data sets like we have in biology. And that's where the excitement comes from. We can take the new field of single-cell genomics and omics data sets, train these models, and they gain an understanding about how genes communicate to each other. If you show them enough data that we may not understand fully how what they learned, but they can use that to predict outcomes at the cellular and tissue and organismal levels, which is really exciting to leverage for when you think about a patient treating them with a particular drug, will they respond or not? So that's where the excitement comes in. I think this has the potential to really revolutionize healthcare, and I hope that AI will bring us to a point where it really fundamentally changes healthcare. I get nervous about growing old because of some of the things I see in our healthcare systems, but there's some things that where the incentive structures are sort of mismatched, where where the institutes get paid for service instead of for keeping people healthy necessarily. And I think AI systems can help us get to a point where we can detect things early and move more toward a wellness situation and keep people healthy instead of reactive and only treating them when they're sick. And that would be, if this discussion goes that direction, that would be, I think, fairly interesting. But anyway, I think just to summarize, the new promise of AI is I think not just helping us as a research tool, but it's changing this paradigm of how we might think about treating a patient from earlier and earlier interventions, especially for cancer. You can detect things that before we couldn't even hope to predict with these new systems, and using, like, for example, using a patient's immune system as a signature for maybe something's in their body before you detect something shedding from a tumor, for example. You might be able to see, oh, the immune system's acting in a way that's a flag. So these kind of things I think, can revolutionize healthcare and maybe ultimately wellness in the future. So I'll just pause there and pass it on. Thanks for taking my initial comments.
Thank you, Dr. Josh Stewart. Our next speaker is Leo Liu, MD. Dr. Liu is a hospitalist with UCF. He has experience in developing and applying machine learning algorithms to healthcare, designing clinical pathways, and evaluating new technologies for clinical practice. He is the Director of Clinical Informatics at St. Mary's Medical Center and the Associate Program Director of the Clinical Informatics Fellowship. Welcome, Dr. Liu.
Yeah, thank you, Becca. And yeah, I'm really excited to kind of talk about this topic and chat with the co-panelists, but also the audience. One small correction: I'm a professor at UCSF, not USF, but one small correction. But yeah, so I guess what I have to say, I guess the first thing I want to say is, like, I think we have to be more specific about what we mean by AI. I think nowadays, like, most people, when they say AI, they're thinking of these like large generative models, like most likely a large language model. But I think it's easy to forget there's this whole field of just traditional machine learning, right? So like your neural networks, your tree-based models, your support vector machines, logic regression, and those have great uses as well. And like a lot of our society runs on them right now, right? And so depending on the use case, those actually might be better than some of the newer generative like machine learning models. So I think it's important to not forget that. I'm going to assume for the purpose of this panel that people are most interested in talking about generative models. And so I'm going to kind of focus my comments in that realm. And so when I say generative models, I'm really focusing on generative large language models. So examples of that are, ChatGPT by OpenAI, Llama by Meta, Claude by Anthropic, and then also what's the other one? Oh, Gemini by Google, right? And so these are things that we're kind of talking about. So in general, I'm super excited by these things, right? These are, like, to me, giant leaps in technology. It's kind of like the new gold rush in terms of like the new word that we're building with this, right? And so everyone and their brother and everyone in their family, every executive, every like politicians thinking like, how do we leverage these tools in that new world to advance our needs and hopefully make the world better? But I think that's to be determined. Having said that, I'm a believer in these tools and I'm excited about them. I have a lot of concerns about them. I'm just going to, point out some of them. Like the first one is, these are, ChatGPT came out, what, a year and a half ago? Yes, the transformer architecture model's been around since 2017, but the things that got the world excited about these tools didn't come out for a year and a half. And so we are in version 1.0 or 1.01. Like, we're in the very early versions of what these things can be and can look like. And so it's going to be a while, I think, longer than we want, and to actually get these things to be useful and to help us specifically in the kind of medicine realm in a very kind of large scale pattern. The second thing I get worried about is that I think we as a society confuse AI, artificial intelligence, with artificial general intelligence a lot, right? So artificial general intelligence is when, like, it's like you gain consciousness, you have reasoning, right? You like, you become Skynet and you destroy the world. But what we have right now with artificial intelligence is not that, right? What we have now with artificial intelligence is really just statistics. It's statistics and mathematics using real high, like, high computing power to kind of make really good predictions, right? And they're just tools. They're not constant. They're not sitting there plotting, whatever. And so I think that's what people get confused about a lot. And I think the danger with that is that we believe that these things can do things that they can't, right? We believe they can reason. We believe they can solve complex problems that we can solve, right? Where in the end of the day, they're really just kind of tools that are designed to address very concrete things. The third thing I will mention, as being from a public institution, I do have to bring up the issue of bias. So these things are tremendously biased. And so let me just give an example of that. So these large language models are trained on internet data. internet data, majority of internet data is English speaking. And so these models represent the cultures, the customs, and just the ways of thinking of primarily English-speaking countries. So if you're a person in Africa, you're a person in Asia, you use one of these things, it's just going to be a little bit off. It's not going to represent how you think and the things that you prioritize and how you express yourself, right? And that's why some of these countries are thinking about, should we create our own large language models that are native to our cultures? So just from a global perspective, they're very like biased towards English-speaking countries. So that by itself, they're biased. But these models are trained on the data that we write, right? Whether on the internet and books or whatever that get uploaded to the internet. And so they kind of copy our issues, right? They copy there's sexism in our country, right? There's racism, there's all other biases and issues, and all these are captured in the internet, and these are used to train these models. So as a result of that, these models are biased. They're sexist, right? If you ask these models how do you refer to doctors, they usually refer them as he's, versus for nurses, they'll usually refer them as she's. They're just propagating kind of biases and inequities in our society. So there definitely is a risk for that, and it's a complicated problem to solve. And plus, like, who gets to define what bias is, and who gets to define when something is not biased, right? It's so hard to problem. Okay, now having kind of said that, I think what you all care about is like, what is the impact on health? And so I'll just say a few things that I don't think can happen, and I'll say a few things that I think can happen. So the things that I don't think can happen, I don't think these things will ever replace doctors, right? I'm gonna be completely out there. I don't, it's just not gonna happen. Maybe less so for performance reasons, and just we as society, we need someone to blame, right? And it's easier to blame this individual doctor who's responsible for that decision than this kind of a massive thing that some company owns. The second thing is that I don't think these things are great at making complex diagnoses. And that's because, doctors aren't great at making complex diagnoses, not because they're bad doctors, but because some, like, issues are just so complicated and we don't know like what exactly is going on. And so when you're asking a system to try to use data that we generate to try to make a diagnosis that we don't even know about, it doesn't make any sense. So I don't think these things will be great at making complicated diagnoses. They'll be fine for simple diagnoses. Do you have diabetes? Do you have high blood pressure? Yeah. But you don't even need a machine learning tool for that. Get a blood pressure cuff, check your A1C. And so sometimes I feel like we're a hammer looking for a nail. The third thing that I will say is that I don't think these things would be great for designing personalized care, right? As I said before, there's no reasoning, there's no critical thinking. So they're not going to be able to come up with great plans that are pertinent to your specific situation. If you look at like the medical recommendation bodies, I think they're usually super generic, right? And it's not surprising they're copying like things on websites and forums which are like, super generic itself. So those are things that I don't think these folks can do, at least anytime soon. Now, getting to what I think these things can do, I think they're great for brainstorming, right? They're essentially capturing the thoughts and ideas of millions of people across the globe. And so if you as a doctor, you're like, this situation is so terrible, I don't know what to say to this patient. Or like, I think this is the diagnosis, but something's off and I don't know why, and I'm not sure what else can be. It can be a great tool just to think about different ideas. And so I think from a brainstorming perspective, it could be a wonderful, useful tool. I don't think it's going to be good at making diagnoses, but as a brainstorming tool, great. The second thing, I think this has been brought up before, is just reducing documentation administrative burden, right? There's a epidemic of physician burnout in this country. It's a huge issue. Doctors are tired, and there's a lot of people leaving the field, unfortunately. And so a lot of health systems are looking at this as the lowest hanging fruit, right? How do we use these tools to decrease physician burden, like generate progress notes, like help them, look at important information or look at new patient, generate responses in basket messages, summarizing kind of discharge screen, so kind of things like that. So that's already happening, and hospitals are kind of using those tools. The other two things I will bring up is health education. So, in a clinic visit, you got 15 minutes of the patient, and I'm not, you got a complicated patient, heart disease or liver disease with like, cancer, and they smoke, you don't really have a lot of time to go through everything with them. And I never know when you end that appointment with that patient, do they actually understand everything that you said? And do they have really, did you really advance their knowledge? And it's going to be hard in 15 minutes, right? But what if you didn't have to depend on that 15 minutes. You can refer them to, hey, use this AI tool that our health system or the government or whoever has approved, and you can ask a question about diabetes, like as much as you can, learn as much as you want about like diabetes, learn as much as you want about metformin. So it's just kind of a tool to kind of help support the patient and learn more about their medical issues, and then they're kind of like help them navigate. The same thing if you're a patient got discharged from the hospital. Do you really understand everything that happened to you? We write discharge summaries, but I don't know if you have the I guess the health literacy to kind of fully understand that. But you can put that in a machine learning model, right? You can summarize that like this is at a 10th grade level or 12th grade level or whatever, what happened during hospitalization. These are the important things to know. This is what you need to do. This is who we need to see afterwards to follow. So I think those are things that these schools can do now. The other last thing I'll say is that I think health coaching is another great utility of these tools, right? So a lot of health is not treating cancer, treating heart disease, treating whatever. It's losing weight, it's stopping smoking, it's stop drinking, it's dealing with stress, dealing with anxiety, and these are kind of very time and human intensive kind of interventions, which our health systems by and large aren't great for because we're squeezed for time at 15 minutes to see a patient in an outpatient setting. And so what if you can leverage these tools, which can give you unlimited amount of time to spend as much time you want motivating, helping patients, like, stop drinking, stop, exercise more or whatnot. So for me, I think those are the things I'm more excited about. The things that are less risky and less directly involved in diagnoses, because I don't think they're going to be as good at doing these things, but more kind of lower risk, but still kind of helpful at a broad scale. So just in summary, I'm super excited about these tools. But I think we got a long ways to go for them actually to make a big impact at a scale, especially medicine. With that, I'll kind of turn it over to my last panelist. Thank you.
Thank you, Dr. Liu. Our next speaker is Dr. Donato Hernandez, MD. He's an internist in full-time hospital-based practice in Santa Cruz County and has been a member of the medical staffs of all the county's hospitals. Due to his role in the continued evolution and promotion of health in underserved communities, Dr. Hernandez was named Physician of the Year for 2023 by the National Hispanic Medical Association. Welcome, Dr. Hernandez.
Thank you. And two other items in that portfolio. I'm certified professional in health information systems, so I'm CPM certified. So I'm an informaticist like Dr. Lewis. And in addition to that, I am the immediate past president of the California Medical Association and represent the almost 56,000 physicians in the state of California. And I'm going to strike a bit more of a cautionary tale with respect to this. And a lot of this has to do with things we're experiencing right now within several aspects of health technology in the broader context. Right now, in California, we're struggling. In fact, throughout the country, we're struggling with a hack that occurred with Change Health, a system within United Healthcare that has basically stopped all payments to physician practices because of that hack. It really, again, with these things, you start thinking about who and whom really owns this data and information. In many respects, one of the things that we've noted, this was just recently brought up, right now there are over 500 new devices and or health-related AI type of devices currently before the FDA for approval. It's exploded. And we're talking wearables, things that you put on your body, things you step on in your home, or various and sundry other items, and you become the product to some extent. And question is, who really owns that data? Who really takes that data and who curates it and for what purposes? One of the things that we're also noticing now, and for those of you who access your healthcare through conventional commercial healthcare markets, one of the things that you've had to deal with and physicians deal with is this thing called prior authorization, meaning for if you have a condition and in consultation with your physician and your healthcare team, you feel that there's a certain study, test, or intervention that you would like. A lot of that has to go through insurance and the prior authorization process, where that's put before a process where that's approved or not approved. Some of these insurance companies are now migrating to these learned machine algorithms for disapproval and non-approval. And as it's pointed out before, humans are complex, several thousand million different chemical reactions going on at any given moment. And, your individuality and your individual needs really become part of that. And I worry about the possibility of these algorithms really taking over a lot of that governing aspect of healthcare delivery. One of the things that was also talked about was the fact that there was bias, but I want to take that the next step. There's not uniformity in the ability to access to these information systems throughout the state, much less our region. There are regions still within the state of California where you do not have access to broadband, internet. And in so doing, is there going to start developing a tiered system where these AI systems and the things that are like that, the augmented learning may not be available to providers throughout the state in a uniform fashion, and thus setting up or at least exacerbating the multi-tiered self-care system we currently have. I was We talk about the ability for these systems to take over a lot of the routine and mundane aspects of what's going on in healthcare, the charting, the documenting. And again, while I think that's really positive, I think that's a welcome thing, we have to really go back and think about the world of unintended consequences. And one of the things that we talked about, you heard earlier, was physician burnout and provider burnout and nursing burnout. And being married to a nurse, I understand the nursing burnout parts of this a great deal. And that was part of the promise of the High-Tech Act when it first was implanted, and that was that we're going to migrate from paper systems to these new computerized systems for both record keeping and all sorts of curated content and archived content. And there would be this ability to move across platforms and have this information seamlessly across wherever you encounter your healthcare. And that really hasn't been the promise of high tech now, as long as it's been in place. And in fact, one of the major reasons, in fact, not the major reason for the cited for burnout within the physician population, is in fact the electronic healthcare records and the care system. If AI can actually unload that and make the high tech part of that promise that we were promised well over a decade ago, that would be great. It's not entirely clear if that is indeed the case, and we really need to be very careful about as we pursue this moving forward that we exacerbate an already existing problem. The question again comes back to, in my mind, not just regulation. So I was fortunate enough to be on a meeting less than a week ago with Congressmember Jay Olbernolte. And Congressmember Olbernolte is actually the chair of the AI committee before Congress right now. There's a lot of interest in where this is going from a regulatory perspective. Who regulates this? Who owns this information? Is it secure? Is this, again, do you have a breach now? Somebody has all your information and things that we're seeing throughout the healthcare delivery system. I mean, right now, there have been several hospitals in Boston and in Southern California where the information has had malware implanted into the electronic healthcare system, and now these institutions are paying a great deal of money in ransom to get their information back and extract it. But you go one step further and ask the question, well, yeah, so what are the security abilities, when now you have this much, much larger and open architecture that people can access? The thing I think ultimately comes down to is the incentive alignment. The one thing that doctors really want to do, and I think all of us can agree on this, at least I would like to think, I agree, we're not going to be replaced. Because the one thing that physicians do for patients within that really sacrosanct relationship between patient and physician is provide context. It's not simply a question of here's a bunch of facts and I can regurgitate those, or I can look up this database that allows me to take these pieces of information and come up with a series of salient diagnosis or issues. What really happens within the relationship between two human beings is the ability to add context to what's going on in your life for your health, how you make choices that work for you within your life, within your life choices, within your needs. And I don't think there's ever going to be a situation where a machine is going to take that over, because the ability for an educated physician or an educated provider or somebody that has the understanding, using that as a tool to broaden the information that you may be able to make those choices from. But that context becomes incredibly important at the interface between both provider and patient. And I hope, I think the promise is at some point that AI will help augment that and provide a better set of information so that you have more choice or more opportunities or more treatment options. But nevertheless, it has to fit with your life because that's what this is all about. Right? None of this means anything if it doesn't provide an opportunity for you to live the best life you can in the best way possible. And so there is a yin and yang in this. There's a give and take in that internal tension between the promise of AI, but what we're currently seeing. And perhaps, yes, maybe the government will invest in a massive infrastructure expansion so that everybody has access to broadband and physician practices in the most remote areas of the state and the country and the world will be able to access that AI opportunity. But then again, maybe not. We struggled with the investment in these things in the past and who pays for it and why they pay for it and on it goes. And who's going to curate that information and who owns that? And are these systems going to be placed in such a way that they're affordable, so that you don't have very, very large medical groups being able to capitalize on their economies of scale, and yet leaving small solo or other people within the healthcare delivery sector wanting for that same information technology. Some people believe that this is going to become a very egalitarian thing where now you have access, everyone has access to these AI models. And while I think that would be great, my past experience and the experience history doesn't always pan that out. And so I think that's really, really important that we look at this from both the justice lens and an equity lens, but also an opportunity lens so that every community has access to this. And the individuals that are taking care of those individuals within those communities can avail themselves of these technologies. Again, there's good and bad with this. And the concern that I have, while I would love to unload administrative burden in massive quantities, I also worry that what happens when you become the product. And we see this more and more and more. And there's a lot of trust. I don't know about the rest of you guys, but whenever I get the Apple update, I'm an Apple person, so I have the update on the operating system either for my Mac or for my phone. There's always an agreement clause, and it's a multi-page piece of information that I sign and I agree, but I've never really read through the entirety of that. And I go forward and forward about who owns the information that I'm accessing and why and who's picking that and making sure very specifically that they're doing it with the intent of and being very intentional on how they move forward with that. So with that, I think I'm going to open it up for questions because I think this is going to be a conversation more than me just standing on a soapbox and talking about, it's good, but there's definitely bad as well. Thank you. I think you're muted.
Sure. Thank you, Dr. Hernandez. That was really great. It is good and bad. It just is real scary. So we have some questions from the audience. I'm going to pass those along to you, and I'm going to ask Dr. Hernandez because I think he has a handle on this. How will AI benefit the average MD?
Well, again, the first thing are these example. One of the challenges, and there's a lot of conversation about that, when the computer was entered into the exam room, the physician's attention moved from that conversation with the patient to this box that had to be plugged and had to be pushed, and part of your value was being able to click the particular boxes or quality metrics and all these other things that external entities really were looking for as a measure of whether or not you were doing what you were supposed to do and hit these metrics in order for you to not only be paid, but also document the things you needed to document. The hopes are that using an artificial, not just a large language model, but something that also has the ability to be adaptive, to take what you speak as you have this conversation in a very organic way and convert that into a document that's usable both as a billing statement, but also as a referral point, so that hey, we can use this future, and patients can access that from online portals that they have control over. Additionally, that the information coming out of that would also be used in a sort of seamless way to get to so insurance companies understand what the treatment options are and why we're pursuing these particular treatment options. I would hope that one day we get to a virtual waiting room so that you never have to sit in a doctor's office. That information is already input into a system. It's virtual. You walk in the front door, you go immediately to exam room, and the medical assistant's there and taking some vital signs if you need, or those vital signs have already been inputted from your home and are now in the system to be used and part of the decision making process. And then the physician can sit in and take that data moving forward. That is the promise. I really think that would help a lot in terms of moving us away from this three-person relationship that exists in the exam room currently: the computer, the patient, and the provider. And by taking that computer out of the way, we get back to that one-on-one conversation that exists between patient and provider. But I thank you for the question.
You're most welcome. Dr. Liu, we have a question about how physicians can prepare to begin to use AI. Is there something in the pipeline to train them, or is there already training available?
Oh, God. Yeah, I think this is a question near and dear to my heart because I think I'm in the middle of sorting this out. So I'm part of I wear two educational hats. I direct the clinical mathematics and data science pathway and also an associate program director for the clinical mathematics and data science, clinical mathematics fellowship. And so, yeah, there's like a subset of physicians who are really interested in this and who can undergo subspecialty training. But I think the bigger issue is this is probably a tool that all physicians need to know at some level. But the question is how much do they need to know about it, right? Do they need to get really into the technical details to fully understand it, or is it okay to just understand it at a high level, right? I kind of think of this as maybe similar to up to date or similar to learning statistics, which is all kind of a core curriculum of any medical student or resident. And so, yeah, so how much of this do you need to incorporate into the standard medical curriculum? But more importantly, what do you need to teach? And that's the harder part because things are moving so fast. What do you need to teach and what's most up to date, what's so relevant, literally is changing by the week, if not by the month. And so, yeah, what does that look like? It's a difficult question. I think it needs to be part of our core curriculum. It's just what exactly and where. I think we're still kind of sorting out.
Yeah, I could see that. It's so new. Yeah, it's hard to grasp it, let alone figure out how to teach it. We have another question from the audience that I'm going to direct to Dr. Stewart. The question is, will AI enable patients to ask questions about their symptoms so that they are more informed when they visit their MD? And I directed that to you because you had the concept of finding things out early and so we can improve patients' health. Will that come into play? Will people be able to maybe look at, I guess they won't look at their own genome, but can they get information from their doctors about things that could happen in the future so that they can be adjusting their diet or their exercise now?
I think it's a great question. I think it has the potential to do that. I think there's the technology could be there, right? It depends how you set it up and whether you give somebody misinformation or the right information. I think a lot of times doctors express frustration when people, Google too much and come there with preconceptions about themselves. But I think ultimately, AI should be able to help with that. I think one of the current best uses of the LLM models is to summarize a lot of text that's out there. But of course, it can make a lot of mistakes. That's always been in the news. The errors and facts can be off, and when it comes to healthcare, that can mean everything. So I appreciate the statements from the other panelists about the use of AI. I don't see it replacing the physician. I would hope that it increases the humanity of the experience. I've been incredibly disappointed, maybe many people have, in many aspects of the healthcare system now, you go in and they ask you to pay first before they even ask you what's wrong sometimes. I mean, AI should help us, I would hope, analyze our systems to increase that physician contact with the patient, like Dr. Gonzalez was talking about. It's like, Hernandez, excuse me, to take away those tasks that distract you from the relating to another human and really figuring out what's going on. Humans are still incredibly adept at that. I see AI as having potential for that. I would disagree a little bit with Dr. Liu about pushing toward complex diagnoses and things like that. I think there's some evidence in the literature already where experts get surprised by what these systems can do. But I would, without going through anecdotal things, I see the promise there. But just to summarize, responding to that question, yeah, informing patients, but not to the degree that they feel like their healthcare is replaced. Giving them information, I think you were hinting at it, before something goes wrong, I think is key. And that has a lot to do with personalizing that information for people, right? Nutrition, we hear about the gut microbiome, genomics does help, right? All that, keeping that in mind to decrease health disparities and increase access, all that is a balancing act, but getting the information correctly to the right people, and tailoring it to them appropriately, right? I think AI can actually really help with that, but it's got to be built, and it's not there yet, and it's rife with complexity. That's a great question.
So I'd like to follow up with you a little on that. There are some companies in Silicon Valley, and I used to be a health journalist, so I experimented with these companies. And you could send them a specimen of some kind, and they would tell you all about your microbiome. And it was really interesting because they would start off with telling you, they would give you a list of your superfoods and things you should never eat. And they'd tell you all about all the bacteria in your biome or your microbiome. And then, but it was crowdsourced. So the more samples they got, the more information they figured out. And so your superfoods would change over time. They would get more information and realize, maybe that's not so good for you. So, what do you think about that? Is there a way to use AI to help people figure out more about themselves, or do we just need to wait for a lot more information before it'll be safe for them to do that?
It's a little outside my area, but yeah, I think it's possible that you're talking about maybe a collaborative filtering kind of thing where people contribute and share their experiences and their diets with each other. Sharing data is an awesome thing, and putting the incentives there and the protections there in place can really power these systems to help people make choices. But it's a double-edged sword, right? It can be used both for good and bad. I think that's an interesting application, and yeah, we're right next to the innovators over the hill. Personalis is a new company. Of course, watch out for companies selling a panacea like Theranos, right? So it's there's limits to what we can still do with biomarkers of different sorts, but yeah, the potential is insanely awesome. For as soon as people unleash data and there's the right protections in place. Yeah.
Thank you.
So, on that, if I may,
please, yeah.
There's two applications here. There's the broad and the narrow, right? The broad being like, how much did I collect on the entire population of the state of California? One of the things that we did during COVID, and it was a measurement of actually the DNA burden of COVID within the effluent at the sanitation departments throughout the state, and you knew how much COVID was in the community based upon the DNA sampling that occurred from the sewage, and things, which was great because that epidemiologically told us that we were having surges in various regions, and mitigation strategies or vaccination strategies could be employed to help offset that, and that's great. And when you talk about the gut biome, are you talking about that as within the entirety of the species of Homo sapiens, or are we going to be able to cone that down to individual groups or individual communities, and even down to individuals who, for various reasons, may have their own microbiome that is accounting for some of their symptoms or issues, superimposed upon the pathology that already exists. The exciting thing, as was mentioned by Dr. Stewart, and I think this is really, really cool, is the idea that there could be targeted therapies for individuals based upon their genome, and how AI can help us develop those treatments so that, one, we really reduce the number of side effects that occur as a consequence of our previous treatments, which were whack everything in hopes that you whack the cancer more than you whack the normal cells within the body, versus something that is very specific and very targeted for a very specific problem that allows for that individual to get that treatment and manage mitigating a lot of the side effects that we're seeing. And it is the promise as you go through and do these broad-based modeling, but being able to sort of individualize and cone it down to the individual person becomes incredibly important. And again, that's where context is added.
Thank you. Dr. Stewart, do you have an inkling or an idea of when something like that might occur, when there might be a personalized treatment plan for people with like serious or chronic illnesses?
Oh, I'm trying to remember the famous saying where we always get the estimates wrong in the short and long term. I can't remember it. It's that's a tough one. I mean, people are working on it as we speak, and I'm sure there will be things along those lines coming out this year, I'm sure. But whether we have generally useful tools, I'm an optimist. There's a convergence of things happening right now in medicine and in machine learning / deep learning things. So it's changing every month. Like Dr. Lee said, it's incredible. The literature is just like, feels like we're at that Kurzweil curve, exponential kind of point. But I mean, 5 years, if you guys want a number, in 5 years, I'm sure we're going to see things like that.
Oh, that's amazing.
Yeah.
So, I'm sorry, what was that?
I said others might have a different opinion. There are these cautionary things that have to be in place, and I don't understand all the regulatory hurdles and things like that. But
I see what you mean. I see what you mean. Yeah, there could be. You might find out. We might not be able to know for a while. Dr. Liu, you had mentioned how AI could be used for health education, and we have a question about that. How could that be employed for people to just learn more about health in general?
Yeah, I mean, like even just the default models these days, if you like ask it, like, tell me about diabetes, like, what does that mean? Like, what are my long-term risks? Like, how to prevent that? It's going to answer pretty well. And it answers pretty well because, like, there's thousands of web pages, or if not hundreds of thousands, that kind of answer these same questions, and just kind of regurgitate that information. So just from that level itself, like, these could be super helpful, right? Like, think of these models like essentially as an advanced fourth year medical student or early intern, right? Their medical knowledge is going to be very solid. Like when you're asking it basic questions, I at least for this iteration, I don't think for complex questions they're going to be any good. That's my personal 2 cents. Will this get better in the future? Yes. Will it get to the point where we get to personalized medicine, which has been the promise for the last 20 years? I'm very cynical. We will make progress, right? But yeah. So sorry, where was it going with that?
Could we sort of could we use AI to deploy just general health ed for like everybody? So students and parents and everyone to just kind of improve their health on their own.
Totally. I mean, like it can serve as that tool right now, right, for very generic, basic information. And there's like all this kind of evolving methods. So RAG, so retrieval augmented generation, and so it's essentially just kind of turning these like large language models into a search engine. And so you can have approved documents with information, and then you can use RAG along the native large language model to give like up-to-date, like accurate clinical information, right? So he wanted a level of safety beyond that. But for things like very basic things, what is diabetes, what is metformin, these current models are probably good enough where you don't have to make a lot of edits. So that is, I think, a field that has a huge potential. I mean, the concern is like, will patients like to do that? Right? Like if they know that you're not talking to your doctor, you're just talking to this computer. And that I think needs to be played out. And that's probably a societal thing where, the younger generation might be more comfortable with that. But, people who are less used to just interacting with computers all day might have more harder time with that. So I don't know. I think that's kind of some interesting thing to play. And, should a health system have like an approved one where it sends all their patients to? Or should a government have one, right? Or like, is there a company that creates one? Like, what will people trust? And I don't know the answers to that. I think it'll be an interesting thing to kind of see how the market plays out.
Well, I have a question, kind of for all of you, and maybe we can just discuss it a little. One of the things in the American Medical Association survey was came back that doctors were concerned what if AI makes a mistake, would they be liable? What do you think about that? Does anyone want to take a whack at that?
Yeah, liability is a big issue for providers, no question. I think again it comes back to in what format was the AI employed by the patient? Was it part of the AI? Was the patient doing it? Was it the physician using it in the context of making clinical decisions based upon it? Or was it, specious information that the clinician brought upon that may or may not have been, the learning models may or may not have been fully vetted, and then therefore you move into that challenge. And it's very, very challenging. Like, for example, right now, the large EHR systems that currently exist, the Epics of the world, the Cerners of the world, the Meditechs of the world, have insulated themselves from responsibility, largely with respect to liability when errors occur as a consequence of those interfaces. I'll give you an example. You write a prescription electronically, but it doesn't get transmitted or something happens within that transmission. The physician is still liable, because the understanding is that you will have there are quote fail safes in that allow you to be safe, and that's not always the case. There are certainly cases that have been brought forth where there was a challenge with the electronic medical record or a discharge or whatever that didn't allow for that. Again, we're talking very, very different models than what we're envisioning from the AI perspective. But I think that's going to become an important question about ultimately who's going to be responsible for the information, and then that information being acted upon that may lead to deleterious outcomes. And that has yet to be worked out. I know they're thinking about that from a regulatory perspective at this point, and particularly, to what degree do people access the litigation and those processes that exist currently within that.
Thank you. We have a question about rural developing countries and rural medicine opportunities. I guess, is there a way that AI could get high-end or advanced medical information or care to areas where it's rural and there's not a lot of big hospitals or universities there doing that kind of work? Thoughts?
Yeah, I think it's possible. I certainly think being to avail yourself of the expertise of very, very specialized individuals. The question is, do you have the infrastructure based upon those items? Is the infrastructure there to allow you to initiate some of those treatments, or are those treatments that by their very nature need to be referred to higher levels of care, tertiary care centers, like UC San Francisco or Stanford or UC Davis, versus those things that you can do in a community setting which may not have those resources. yes, you can do the diagnosis, yes, you can have information, but as you pivot to the treatment options, now it's question is, does the infrastructure exist in those regions, those areas of the world, or areas within the rural parts of the United States that allow for that? And there may not be. The other option is that individuals can access physicians and specialists at home and be able to have those visits in a very, very real way. And the data or the information, you set up a hospital at home model, for example, that measures your weight or your oxygen saturation or the various parameters of health that, would allow you to manage complex disease states at the point where you really want to do that. And that's with the patient, empowering the patient to take control of their healthcare choices. So again, it's a risk opportunity situation. I think that there definitely has to be an investment in the infrastructure to allow the more remote parts of not only California, but the United States and the world to be able to access that in a way that it's more seamless than it is currently.
Mm-hmm. Thank you. Thank you. We have another, one more question. This one I think is probably best answered by Dr. Stewart. What are the biggest opportunities and challenges for AI in oncology? That's a big question. I decided to pick one part of it.
Yeah. Oh, well, I don't, a lot of it is the challenges and opportunities kind of are more general than AI, right? I think a lot of the things we talked about tonight were some of the problems just with the healthcare system. We heard about it making, I think, just to go on what we recently talked about, okay, it made a mistake, right? What's going to happen? Well, how many mistakes are made right now? So it's like, do you quantify can we quantify how often, somebody in regular practice is going to have some issue in their decision making or so forth, and then you could maybe see it as AI help in those cases. So really, like, getting a handle on where is it going to benefit and where, and not being, I think, scared of the potential risks at first. I mean, like was mentioned, the regulatory structure is still being worked out, but I guess it'll be interesting going forward. For oncology, specific to cancer, I think everybody knows as the cancer is there longer, it becomes a harder and harder problem because it's sort of via selection, evolution in the body, it's become something hard to treat by nature of it being heterogeneous and complex. And so the challenges, like I hinted in my opening remarks, is to get early and an earlier ability to detect these things, but then you face the challenge of, are you detecting too much, right? So I think the vision, in the future would be in the blood, if you have a little spike of, oh, you have some kind of neoplasia or something turning toward cancer somewhere in your body, we can't freak out and start treating it, but you have a data point that you track over time with a person, and that becomes part of somebody's personal record. And this data point idea, right, is not just specific to oncology, it's specific to everything, even the temperature that you take in somebody's body. Nobody's 98.6 degrees, right? Everybody has their own temperature. And so establishing everybody's baseline of every kind of data point we can is the way you start to treat people better without, like, applying just one rule saying, okay, if you're above 90.6, you have a fever, right? It's the same kind of thing, I think, with these detection systems that we now could put in place with the promise of AI to be very specific to a person, detect these things early before they're a problem later on, and send somebody to the next test if they see a trend going upward in time that's worrisome, not just one single data point like we kind of work with now in the hospital. So anyway, there's many things. I guess I mentioned a couple there. I'll stop so I don't go on and on. But I think it's a very hard, interesting question.
Aren't they all? All the AI questions are hard, I think. We have, I think we've got 4 minutes left. So I wanted to give you all a chance to say one thing that you think is really important for people to know that we maybe didn't talk about, or reiterate something that you think is really important. I'll start with Dr. Liu, or sorry, Dr. Liu.
Oh God, I was thinking. Oh my God, what did I say? Well, yeah. So I think the toughest part in medicine is how we get these tools in, and like what is the business case of these tools. And the challenge, I think, Dr. Sur, you brought this up, right? It's like by and large we're a fee for service kind of service, and so like how can these tools actually help us when our payment model is like that? And it's going to be challenging, right? Because we make money by seeing more patients. So how do we change the incentives where, like, using these tools can make people healthier, and then that will actually lead to better outcomes for the health system as well. So I think right now, like, are these tools more costs? Then, like, can you prove that there's going to be ROI on these tools, and can justify buying these tools for your health systems? And I think that it might be a hard business case to make. And I think being able to make that an easier proposition for health systems will be a good thing. And I don't know if that comes from the government or whatnot. So I think that would be kind of one thing that would be really cool. And I think the second thing is I'd like to see more companies get into this space, right? Like, we're really dependent on essentially Epic, really, and also partly Cerner, on how to deliver these tools like into our hands, right? And so we kind of felt like we're all stuck. It's like they don't do it, we can't really use anything. And I'd like to see more companies get into the space. I'd like to see more competition, because I think it's a really exciting space, but it's just dominated by Epic, really, and then somewhat Cerner, and which limits innovation and limits like a lot of things.
Yeah, so true, so true. Well, we have 2 minutes left. Dr. Hernandez, do you want to make a quick?
Yeah, I'll make a very quick plug. I think when I think about where we are right now, and the model comes to my head, and I know this is not AI necessarily, but social media has really pointed out the fact that while people were leaning all into that, it didn't make us happier. It didn't make us healthier necessarily. And AI may have that same promise. I think what we see, particularly in a healthcare setting, is connection with a physician, connection with a healthcare system that's functioning at a high level, and hopefully AI gets us to that point where we know the problems, and we can certainly get our incentives aligned, as well as trying to resolve these problems. It gets us back to that human connection that really leads to good health, that allows people to make choices that work for them. Then yes, it will fulfill all the promise that we see in the future. It's a big if, but I think what we really ultimately get to is the fact that what we really all seek is connection. We're social creatures. And anything that enhances that ability to make the connection and makes us better, feel better health, provides for better communities is worth it. And I hope that is eventually where we get to with these tools.
Thank you so much. I'm sorry we're out of time. This discussion could go on and on. I want to thank you all. Thank you, Dr. Liu, Dr. Stewart, and Dr. Hernandez for joining us tonight for AI and Medicine. And thanks also to the Santa Cruz Public Libraries. For CTV, I'm Becca Reed, saying thank you and good night.